Well, good afternoon, everyone. Thank you for having me and to be part of this really exciting conference. It's a little humbling to be facilitating this section, but I have a couple of just kind of high-level thoughts, and then Shelley is going to share her perspective, and then we'll open it up to the questions and try to direct the questions to the most appropriate person to address them. So a couple of things that struck me, Dr. Schrag and you and Nichols all shared with us just some of the very many challenges, including lack of funding for doing health economic analyses. But, as I was thinking about it, kind of overarching, one of the overarching questions, save maybe for the prevention and screening area, is that there's, I think, often a reluctance to even use economic data in treatment decision making. And so I think that's, one of the big lingering questions is, how is the information going to be used? Is there a way for it to be actionable? Because having more economic data doesn't necessarily help us if people don't use it. And as someone who spends, much of my day trying to figure out how to make cancer care affordable, I think, a number of the challenges that have been discussed that are being thought of from a more research internal validity perspective are things that I deal with in terms of, having actionable information every day, because I design programs to try to impact the cost of care. So, as I was thinking about it, I wondered if, one of the potential areas that NCI could support and that might interweave with all of these issues that have been discussed is, do we need to come up with metrics that would allow us to evaluate the impact of the various programs that are put in place to enable access and to impact costs? So we've had just comments on benefit design, and I think it was Dr. Wang that mentioned that $100 copay was enough for one of his patients to forego colonoscopy screening that was needed. Yet, on the other hand, benefit design and higher, more skin in the game is viewed as a key strategy by many policymakers in the United States to control costs. So, I wonder if there's something like, for diagnostic tests or screening tests, we use sensitivity and specificity and other metrics to give a holistic view of, the missed opportunities, how well we're doing. Maybe there's a way to do that, to compare different initiatives to impact cost. And, even though that's not exactly the same thing as having all the data up front, given, I think, as has been just, it's described, it's a moving target. We can do a cost analysis alongside a randomized controlled trial for a treatment. But then, once that treatment comes on the market, you're really comparing it against 12 other treatments, and then there's sequencing and also a whole host of other things that make it very challenging to know how, what the external validity of that analysis is. So I'll just kind of throw that out there. Maybe it'll be good food for discussion. And Shelley, interested in what you're thinking.
Thank you. I just saw a comment that, there's a reluctance from Arden Morris, there's a reluctance for clinicians to use economic data, but patients are constantly using the information in their personal decisions. And I think that's what's so important, is that why this information is really important. And I love the recommendations that the treatment group made to try to think about how we can do this economic analysis at the same time we're doing the studies, because, we don't want to believe that cost should affect decision making, but it does, and it does for a lot of patients. And maybe, there are differences when you have something that would be, curative, and you don't want cost to impact it, if someone not to get access to something because of cost. But when you're talking about something that, may have a more incremental benefit, and, we don't want patients to have to turn down treatment because of cost, but sometimes that's just part of their decision making. And it's maybe not the only factor. It's part of, it's thinking about, the benefit and the treatment side effects and the cost. And, patients say all the time, I don't want to put my family into debt, or I don't want to use my savings and my retire, I would like to leave that to my family if this isn't going to help me. So I think being able to really look at the benefit and cost altogether would be incredibly helpful. But I think to some degree there's not, I know there's a lot of barriers, but I think there's also a lot of political will that would need to be summoned by a lot of people to be able to do that. But I think it is really important. I really appreciate that both of these presentations talked about the indirect costs and really looking at the total cost to patients. It's not just about their copays. It's about all of the indirect costs that they face, both medical and non-medical. And I also really appreciate the attention on caregiver costs, because it is such a burden, and so many caregivers end up taking off of work or even leaving jobs to take care of somebody, and that's not ever really considered in these analyses. But I think it's really important. One thing I think we also need to include is mental health costs, because so many cancer survivors need and seek out mental health support, and we need to make sure that that's part of because it is some may have been receiving mental health support before their cancer diagnosis, but often it's the cancer diagnosis that propels them to need that. So I think also looking at the long-term burden on survivors, and it's a little daunting, all of the barriers to really having that data. But I was interviewing some survivors yesterday for a project we were doing, and it just is it's so daunting to think about all of their long-term sequelae of their treatment and what that means for their lives, and how they have to see multiple specialists to deal with all of the different side effects of their treatment. And I was talking to one woman who's more than 40-year survivor of Hodgkin's lymphoma. So she's had all kinds of different treatment side effects and additional cancers, but also a young woman who's a colon cancer survivor who has kidney issues and has mental health issues and has fertility issues. And she talked about what she has to do to manage all of this and keep all of her different specialists in the loop. And it is really unbelievable. She's had good insurance, and so I think she can manage her personal costs. But when we think about the long-term survivors, it is really a big picture of the cost to them, both the financial cost, but also the indirect cost of managing that care. I mean, for some of them, the way they describe this, it is like they have a full-time job to manage their survivorship care because of all of the effects of their treatments. And I know that's not all survivors, but there are definitely some that is the case. So I think when we can look at costs broadly, that is helpful to understand the true picture that they're facing. So I haven't looked at the questions yet. Jen, do you have any questions that we could pose to start?
And you might be muted on your phone again.
Thank you. So maybe this is a question for Dr. Schrag and you. It seems with some studies using all payers claims data with perhaps some subset merged with clinical data would be a way to test whether how claims get us far enough. Those comparisons are not feasible, but can be interesting. Dr. Schrag, I think you have some experience using these kinds of data. Do you have some thoughts on that?
I do. I think that all payer claims data are really, really helpful. I think one of the challenges with all payer claims data is if they report claims, they're reporting the claims and the prices for that insurer. So often what we like to do is to look not at the cost estimate, but at the utilization data, and then standardize it. And so standardizing it, often a nice approach is to just standardize everything to CMS costs. It depends on the question, but when I say, I mean Medicare costs. So if you're trying to compare what is the cost versus treatment A and treatment B, and you go into all payer claims data, you have all the challenges of any analysis where you're potentially plagued by selection bias. So, did people get this hormonal treatment or that hormonal treatment. You can compare, you can look at the costs, you can do it using all payer claims data, but you may find that, for example, one insurer covers the newer, more expensive agent more readily, and one likes to stick with tamoxifen, for example. So you can have policies of the insurance payer mix really influence things, and then you really have a selection bias issue. The other approach is to just look at utilization, convert everything to unit Medicare costs. So I think those analyses can be powerful, they can be provocative, they can certainly give you large sample sizes quickly and efficiently. So I think it would be really interesting to go to an all payer claims database and say, what does it cost to give the typical lung cancer patient immunotherapy? And you would see that people aren't staying on immunotherapy necessarily for as long as you think, and that the big cost drivers of immunotherapy may turn out to be the hospitalization costs. So I think there's real benefit to doing it. When it comes to causation, I think it's very tricky, even with all the econometric gymnastics and causal inferencing model and all the statistical jujitsu. You do run up against some limitations. But there are many fantastic economists on the call who know all those jujitsu techniques and would be better equipped than me to comment on how much you can push the envelope. So I think they have a role, but it's limited.
And I'll just add, this is, hi, it's Robin. I know that there have been some efforts to link cancer registry data to all payer claims data, which tends to help with some of the key clinical issues that are not available in claims data. And I don't know if Kathy Bradley is on. She was the leader for the survivorship group, but I know she has an active project linking all payer claims data to registry data in Colorado.
Yep.
So that is another way to have, there she is.
Hi, Robin. Thanks for the shout out. Yes, we do. And we have linked the Colorado all payer claims data with the Colorado Cancer Registry. So has Huntsman, the University of Utah's Cancer Center as well. And we've been looking at trying to collaborate with them and to, see how far we can push things. And we should have some methods papers coming out soon to talk about agreement between the registry and what we find in all payer claims.
Well, I wanted to ask a question about caregiver data. There was a comment that caregiving data should start to be much more widely available now that several states mandate hospitals collect this information upon patient hospital admissions. It's got to be somewhere in the EHR. I'm just wondering if any of you can comment on how do we improve data collection on caregivers and the caregiver burden. Anyone?
So I'm happy to try to tackle that one. I admit a lot of patients to the hospital, more than I care to admit. I'm not even going to talk about during the COVID pandemic when their relatives are on an iPhone in a parking lot and not even allowed to enter. But even under normal circumstances, rolling back a year, it's really hard to operationalize. And just saying you must collect this data fiat without providing an infrastructure and easy mechanism means that most of the time it doesn't happen, even in well-resourced health settings.
Yeah, and I'll just add, I think it's an excellent question. One of the challenges, the data may exist within an individual hospital EHR, but getting it out of the EHR in a standardized format is a more complex approach. I think definitely something we should be working on collectively, but can be very complicated to implement and do quality control checks on. So I'm very glad to hear that it is being collected in most hospitals now.
What about, as, I think, alongside clinical trials, and I know the focus here has been on kind of economics, which we tend to think of as the financial impacts. And, I think, as I mentioned, when in my opening remarks, there's a lot of, I think, challenges sometimes to the external validity of the utilization and financial data collected alongside a clinical trial, although it's certainly very useful for that treatment comparison. but I think there would potentially be more opportunity for indirect comparisons of caregiver burden. So how feasible would it be to have, just as PROs, I think, have now become a fairly standard expectation that you're going to collect quality of life data in a clinical trial and report on that, to have a standardized measure of the burden of treatment, in terms of time and maybe some economic cost to the patient and their caregiver, that would be standardized, right? So that you could, at least at a holistic level, have that, and even if it would be standalone, so that you'd have enough of a quantitative measure that you could then do indirect comparisons across other treatments and other trials, so that it wouldn't just be relevant when you're comparing it to the treatment, the control arm in that specific trial. Because Shelley and I are often paired up on these panels, and I agree with her completely that we can get, as an insurance company, it may not be perfect, but I can get some data on the financial costs and the hospitalization rates associated with different treatments in my population. But there's no insight that, any of us have really, except, anecdotally or in rare circumstances, to the really tremendous additional burden that many of these treatments put on patients and their families.
I think the analogy with PROs is spot on. I mean, when you put in PROs for a clinical trial, it's the tension between making it feasible and then asking for what the PRO people want, which is like 12 different survey instruments every month. So, I think for caregiver data, if you're going to mandate it for clinical trials with the relative lack of support that Dr. Schreck very much outlined, it would have to be very, very simplified. And I would say only at very few time points if you want to mandate it. Or I would say let's throw in some funding for that data collection somehow, some sort of infrastructure to make it easier. But if the analogy with PROs is spot on, I would say stay simple, do the minimal, really, and that's better than what we have right now.
Yeah, well, and really it should, to a certain extent, your lost time, right, should be considered like an adverse event. So if it takes you 10 hours a week to get one treatment versus 5 hours a week for another, that's a meaningful difference.
Right, especially if it requires both patient and caregiver to take time off from work. And then that also depends on the situation and whether the patient and the caregiver both have paid sick leave.
Right.
Which is increasingly an issue that we've been thinking a lot more about during the past year, the importance
of. But you wouldn't necessarily, I mean, just kind of going to the point of keep it simple, within the trial, you could collect whether people had paid sick leave or not, but just knowing the time available, right? And then you could always, impute from other data what % of the population would likely have paid sick leave or not, and that would likely vary in different states and populations. And so just knowing the time is probably enough, or, some version of that.
Yeah, I agree. And I think it's a really important and understudied, under-evaluated issue is the amount of time that patients are spending receiving care and their families.
Yeah.
Well, I think that's one of the benefits of telehealth right now too, is that, potentially something that would take 4 hours or 6 hours or, with travel, parking, all of that could take a much shorter amount of time because, and obviously not everything can be done via telehealth, but I think there's advantages to patients who have so much of a burden of taking time off for all these visits to be able to accomplish some of them in a way that doesn't require that time off and travel time and parking expense and all of that.
Yeah, and I think, and just linking back to the, the survivorship questions and the comments that you made, Shelley, with survivorship, is that then if there, it would be good to tie, in an ideal world, you'd also tie that into what the late effects or the long-term side effects are, because it may be one thing, if you have 5 hours a week or something with one treatment versus, no time, or minimal time, but then you have a 10% chance of an adverse event, a side effect that's going to keep you going to the doctor for the rest of your life, once a month or something.
And bringing up what was said about the time of treatment, I think the tragedy of COVID also presents an opportunity for looking at simplified treatment. A lot of cancer centers were trying to have much fewer numbers of patient interactions, et cetera. Radiation treatments. Everyone's moving towards hypofractionating and shortening the course in the COVID era, and so it'll be interesting to see how the outcomes potentially have changed if there's some way to tease that out from the COVID itself. But a lot of opportunities there in terms of treatment shortening.
Mm-hmm. Almost thinking of it as a natural experiment where treatment protocols have been changed.
So there have been a number of comments here in the chat regarding study sections and the challenges of getting health economic analyses, having challenges with reviewers and whether or not PIs are qualified and different approaches. Is there someone from NCI who wants to take on some of these questions and comments?
And I know we'll be.
Oh, I guess we've been told that we've reached the end and we should be wrapping up. Okay, sorry. I guess we're at a break time, so that could be left to later.